You're listening to the Beyond Nurse Residency podcast, an educational series where we interview experts on all topics related to the transition of new graduate nurses into practice and beyond. I'm your host, Nicole Weathers, Director of the Iowa Online Nurse Residency Program. Thanks for joining us. Let's jump in. I visit with nurse leaders and nursing professional development practitioners nationwide nearly every week about bringing our nurse residency program to their organization. Some are interested in implementing a program due to the impact residency programs can have on retention, while others are hiring new graduate nurses when maybe they previously didn't need to. They recognize that the ever-changing healthcare landscape leaves new graduates struggling to make that transition, and they want to offer support. Whatever the reason for their interest, the ultimate goal is to give these new graduates the tools and resources they need to succeed in their first year and set the stage for a long and successful career. Whether we are talking about nurse residency programs, orientation, mentoring, or any other professional development activity, one thing NPD practitioners continually face is showing the value these activities bring the organization and make the case to allocate portions of their budgets for implementation. In this episode, we will discuss critical components for demonstrating the value of NPD activities, why financial acumen is vital for leaders today, what should be included in a program proposal, and so much more. My goal for this episode is for our listeners to walk away with actionable steps they can take to improve their ability to make the business case for these vital activities. So I have with me today our guest, Cathleen Opperman. Welcome, Kathleen.
Hello.
Thank you so much for being here with us today. Why don't we start off by having you take just a few minutes and tell us a little bit about yourself?
Well, as you said, I am Dr. Cathleen Opperman. I consider myself an all-Ohio educated nurse because I was raised in Toledo, Ohio. I have my bachelor's from the University of Cincinnati, my master's from Wright State University, which is in Dayton, and my doctorate of nursing practice from the Ohio State University here in Columbus. With certifications in professional development, evidence-based practice, advanced nurse executive, and pediatric nursing, I clearly don't want to limit my possibilities. I have been in professional development for over 37 years, and I work at Nationwide Children's Hospital in Columbus, Ohio, as their first ever evidence-based practice nurse specialist in the Center for Nursing Excellence. After 4 years on the board of directors for the Association of Nursing Professional Development, I recently was invited to join the editorial board for the Journal of Nurses in Professional Development. So I'm just starting that role, and it's very exciting. I like to present, consult, and publish on all kinds of topics, including developing educators, anything with the EBP process, change management, return on investment for professional development activities, relationships and communication in the workplace, and numerous pediatric topics. I am excited to talk to you today about business acumen and the nursing professional development practitioner.
I love it. I love it. Well, thank you so much for giving us that little introduction. And I will tell you, I learned a lot about you in that introduction. So I know I actually approached you at the AMPD conference and I said, hey, I'm in my DNP program. I had to write a paper about making the business case for my financial management class. And I went to the chapter of the core curriculum, AMPD book, and I basically used that to understand everything that I needed to know for this paper. And I think this is a topic that many of our partners need help with. And who better to help me bring that message to them than the person who wrote the chapter in the book to begin with. So I am so grateful that you are here with us today and you're going to share all your amazing expertise with our listeners. So let's start with the basics. So we know each nurse's professional development journey takes them on a unique path. I started working clinically in an area that many people run from, but med-surg. It was like I loved med-surg. I eventually found myself in nursing professional development. And when that happened, I really recognized that nursing school taught me the ins and outs of clinical patient care. And even though I had an interest in teaching, it didn't prepare me for teaching. And so that's when I enrolled in my master's degree program that focused on nursing education. And that served me really well in that role. However, as my journey sort of continued, the need to better understand the business and financial side of what I was doing became ever present. So the kicker, though, was that neither my bachelor's nor my master's degree really included anything business related. And I know that I'm probably not alone, right? So before we dive into specifics around the topic, I think maybe we could start with getting a little bit of the lay of the land and have you talk about why this topic is so essential for nurse leaders and nursing professional development practitioners today.
I think we start with some definitions. And I think if we use these terms, let's make sure we all understand them the same way. And so I want you to get comfortable with these. The first one is the word acumen, which is a great word. And acumen is the ability to understand concepts and think quickly and use competent judgment pertaining to that given area. In our case, finance. So then what is financial acumen? The ability to understand, think, and judge the effects of finances and communicate it in the language of finance. And boy, there's something that as nurses we really stand away from. We're like, well, I'm not concerned about that. I'm taking care of my patients. If you want to be able to take care of your patients better, you need the resources for it. So we need to build our knowledge of that language. The next word is business acumen. So business sense or business savvy, and it is an ability to understand the operations situations and respond to them effectively. Clearly, having financial acumen helps your business acumen because they're part of it. Not everything we do in our business acumen is about finances because it's, the operations, the staffing, those kinds of things. But finance is a segment of that. Human capital, that's another term we need to talk about. It's one more word I want to introduce to you because according to Kimberly Amadio, human capital is the economic value of the abilities and qualities of labor that influence productivity. Now, these qualities are like education and health and on-the-job training. When we work in a knowledge industry, which we are in healthcare, it's the knowledge of our nurses, the knowledge, the experience, the skill of all of our interprofessional team members. This is the capital of our individual organizations. And we need to build this human capital, not only in numbers, but in their capacity to do all of these things, because that makes our practice, our care better. But we also have to know that those people, when they leave, they carry all of that with them. It's not like capital, like buying $1 million piece of equipment. The equipment stays here. And so when we're in this business, we really have to understand the significance of our human capital.
I love that you put it that way, though, because I've never really heard somebody talk about some of these concepts in that way. So, I mean, I'm ferociously taking notes as you're talking here because I know I'm going to learn so much. The idea that they take it with them, right? So we're building this human capital, but when they leave, it doesn't stick around. And I just think that that is such a great way to look at the impact of turnover and retention in an organization. So I really appreciate you taking the time to put those words out there for us to kind of think about.
Well, your question was, why is financial acumen essential for nurse leaders and NPD practitioners today? Well, decisions are made by those understanding the financial impact of situations. Yet the work of our industry of healthcare is clinical. We need more clinical people, nurse managers, physicians, NPD practitioners, to learn the language of finance, to sit at those tables, to inform the financially strong decision makers of the clinical impact of choices. We basically need to speak both of these languages, the language of clinical, the language of finance. And you know the adage, the age-old adage, if you're not at the table, then you're probably on the menu.
Absolutely. And I think so many of our partners that we work with have felt like they're in this place before, right? That they know why having a, let's say, nurse residency program is important. They know the value it brings, but figuring out how to put that into a language that the financial decision makers understand, and that you can kind of get your point across for what maybe the impact would be if by not having a program. I think that is kind of the biggest challenge that they sometimes have. And so a lot of times they are on the menu because they're not at the table because they don't know how to speak the language. So I am hoping, and I'm sure that you will tell us by the end of this podcast some of the important things that we need to know about the language. So a lot of people I talk to, like I said, are working to make the business case for implementing a residency program, a preceptor program, or something similar. And so while the purpose of all of these activities is slightly different, I assume how you make the case is pretty standard. So maybe we can dive into that a little bit more. So what are some of maybe the key components you feel should be included when a NPD is putting together a business plan or program proposal for implementing any of these NPD activities?
Okay, well, another term for that would certainly be a business case. And a business case is a written explanation of how the benefits of a practice change, and in our case, the professional development needed, outweighs the costs of doing that change. And therefore, it is the why we are doing something. So business cases include, there's like a certain stack of things that are traditionally put in business cases. They include the objectives of what it is you're proposing, the expenses anticipated, and the counterbalancing benefits. Otherwise, what are we going to gain by putting out those resources? Even if only reported as a cost avoided. Cost avoided means, for example, let's say whatever you're educating on reduces a bloodstream infection. And I'm not sure exactly how much a bloodstream infection is, maybe $45,000, $46,000 per infection. So if we could avoid the costs of taking care of somebody who now has this bloodstream infection, it would be a lot of value, like $46,000 worth of value. And so suddenly your little $3,000 professional development activity doesn't sound so expensive. And so we didn't, actually write a check for that. So it's kind of hard to say it is a cost that is avoided because last year we had 10 and this year we have 9. So we avoided that cost. So what are the components of writing up a business case? Well, there's lots of places you can go, but I really like Welsh and Smith. They suggest 8 components. The first is the executive summary, as it sounds, brief overview, key points. The second, getting right to it, is your proposal. The current situation is this, and we have this problem. This is why this program is needed, and the purpose of doing it. The third component is options. You always want to be unbiased in the sense that you give the decision makers, there are other options. And by the way, there's always the option of not doing anything. And sometimes we call that the risk of ignoring. This problem will just continue, but sometimes the expense of doing what you're proposing is so great and the risk is rare that, they waffle on that. So options. Now, there also are options like instead of, teaching everybody to do something, we're going to buy this expensive piece of equipment and have the equipment do it. So, there's always something that you should present. So that's the third component. The fourth component is somehow giving the decision makers in the most efficient way possible the whole picture. And I love SWOT analysis for that purpose. What are the strengths of this thing I'm proposing, the weaknesses of this thing, the opportunities we have, and the threats or problems we may get from it. This includes, the champions, the stakeholders that would all be feeding into the success or not of your proposal. So we've got executive summary, proposal, options, and SWOT analysis. Let's go on to number 5. 5 is the goals and the objectives. And I like it in bullet points. I am not a narrative, give me 12 pages to read. I like bullet points, boxes, and get to the point. And most of these decision makers you're talking to have so much to read on a daily basis that if you want their attention, you better be succinct and you better put some bold words and some bullet points so that they can quickly skim it. So that's 5. Number 6 is the implementation plan. So we've proposed this thing, we've told you the options, we've swatted it all over, we said the objective and the goal is this. Now, how are we going to do this? This is our timeline. These are the things we're going to do. We're first going to teach them this, then we're going to install the reminder system, and then we're going to, do this third thing, right? And so it can be very visible how long each of these steps is going to take, how much time will be involved with the learning, etc. That's number 6. Number 7, the evaluation plan. Do not make a practice change of any substance without measuring it before and after. You have to figure out if what you just made the hooey of to change our practice, if it made a difference. And I say made a difference because did it make it better? Did it make it worse? Ooh. Or did it stay the same as far as your outcomes? And a lot of people say, oh, it stayed the same after all that effort. I always say, no, wait a minute. Before we blow it up and go back to the original, are there things that you didn't necessarily measure because you weren't focused on that you anecdotally probably found out, hey, this is great. Now people really like it for this, that, and the other reason. So we gained something. So make sure before you go backwards that you fully evaluate it.
Well, I want to pause there because I think that this is an often forgotten, glossed over step for a lot of people, that they get it implemented or they just focus on one thing. So for nurse residency, a lot of times that's retention, right? So it's retention. And if we didn't retain them, then the program must not be doing its job. And we should just, like you said, revert back to the original or, get rid of it altogether. So I don't mean to, take you off course, but I just think that that's something that I just wanted to point out because I do think a lot of people miss this evaluation piece and they often put all their eggs in one basket.
Well, actually, this is one of those things that deserves repeated mention. So I love that we're saying it now, and I will bring it up later. What I will put in as the seed at this point is that be sure that you consider not only patient outcomes, that we now have an improved number, patient errors or whatever it might be. We can consider employee outcomes, which are things like preceptor satisfaction, retention, things like that. We can also look at organizational outcomes like patient volumes and things like that. And so don't get yourself, as you just said, all pigeonholed into one evaluative measure for especially a large program like a residency. It could potentially impact all kinds of things. So you want to think about all the potential outcomes it could impact, and you just keep a running look at all of them. And when any of them, significantly improve, you can report out on that. That was a good pause. Well, the last of those 8 components is the financial impact. And the financial impact is, the data, the projections, the expenses, the revenues, the risks, the benefits. So those are the 8 chunks: executive summary, proposal, options, SWOT analysis, goals and objectives, implementation plan, evaluation plan, and of course, the calculation of financial impact. Now, I think for this podcast, I'd like to concentrate on a few of these components because some of them are a little more self-evident and you can look at examples and very quickly ascertain what you should write for your own project. But a couple of them I think we should focus in on. The first is the proposal itself. This is the purpose. You are somehow showing the gap between what is needed versus what we have. So it could be a clinical gap, like skills or knowledge about an intervention. And this would mean that the proposal is teaching knowledge about and practicing skills for the intervention. Or maybe it's a non-clinical gap, like burnout or engagement in or team relationships. And you've heard it before. I just want to do my work. I don't want to get involved. And nothing ever changes around here. So why waste the effort? This is this culture, this feeling in an area. This is not something that you can just send a module about be nice, be happy, get involved, and get 100% on that post-test, and everybody will be fixed. Clearly that takes motivation. It takes getting them to understand why they should be involved, why that makes a difference. The professional development activity will initially have to motivate, and then you'll have to give them tools and skills and practice with scenarios of how to communicate and strategies to collectively impact a change in the culture. And as you can imagine, if your goal and your objectives is to move that culture, clearly your education is going to be much more involved. It's probably going to be layered over a period of time. It's going to involve a lot of involved learner activities, not passive, I read something, or passive, I just watched a video. If you really want to change their behavior, you're going to have to help them practice a behavior that is different. Another component that I'd like to focus on beside the proposal is the implementation plan, outline, the timeline. So what are you proposing? A module, an in-person workshop, a virtual webinar, a podcast, blended learning combination of something that's self-paced and that something that's in-person? Be sure to provide the NPD practice judgment reasoning for the learning strategy selected. And this is really important because sometimes decision makers think that NPD practitioners want everything to be taught in person with very expensive strategies. And they'll say something like, can't we just, email this out and tell everybody to do it a different way? Well, if it's a simple thing like turn the gadget to the right instead of the left because our new vendor is the opposite, well, yeah, you could send an S-bar out and everybody can read it and show them a picture, right? If it's one of these behavior changes, telling people to be nice and, say thank you and do blah, 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 that's not the way to change it. You really need them to feel moved to change behavior. Educators build influence in their organization by matching the most efficient and effective learning strategies to the situation. This NPD practice judgment evolves with experience and ongoing role development of the NPD practitioner. So basically what happens is as you develop your NPD practice judgment from experiences and matching the best learning activities with the problem, you get that respect and you grow your influence so that the next time you ask the powers to be, no, we really need to do a workshop on this. This is not a self-study module. They listen to you because they say, you know what? She's always been pretty efficient in the past. And if she really thinks we need more to make this change, then we should do it. Most of us who've been in these roles for a long period of time have experienced where we didn't make our case well enough or our leadership didn't listen. And we were told, nope, don't do it that way. Do a module, send it out, and it'll all be fixed. And so we push out this thing and 2,000 people do the module. And then 6 months later, we have a committee come together and say, you know what, we really have a problem with this. And we're like, we know, because what we did 6 months ago was really, we did it to check something off, but we knew it wasn't going to make impact. And so this is, that was expensive. We wasted that 2,000 people doing that 30-minute module. We wasted another 6 months of time that we let this thing continue. And so do it right from the beginning. But you got to develop that judgment and you got to develop that respect and influence. So what else do we include in that plan? Well, estimate the time to develop the learning activities and the resources needed. And I think this is so important because too often, and I don't know whether it's an educator thing or a nurse thing or both, we always want to not make a big deal of the effort and the time it took us to put the thing together. So we say, oh yeah, it was like 2 hours. And I'm like, no, it wasn't. It was like 28 hours for you to put that thing together. So why'd you only ask for 2 hours? Because next time when somebody is being honest and that it really took 20 hours, they'll think, oh, are you slow? And they're like, no, the other guy didn't put the real number down. So please put realistic numbers when it takes you that long to develop something.
Well, I would even go as far as to say, take credit for just the time it takes in general, because I feel like so many times you talk to people and it's like, but your time is worth something too. And so if you can do this and free up some time so that you're not spending time doing all of this, but you're actually out there with the nurses, helping them at that point, that is worth something. And we are terrible about that.
I know.
Why is that?
And if we said, okay, it took me 30 hours to develop this thing, that over a matter of probably 3 or 4 months, the time I gain back because I'm not repeating this concept to 2 people, to 1 person, to 4 people, to 3 people, over and over and over again. I can say, hey, please go do that first, then let's talk. That now frees me up, as you said, to spend time doing other richer experiences. So in this plan, also include how long each portion will take. Let's say, you did a combination and, it's going to take 75 minutes for them to do the self-study module. And then we're going to have our 3.5 hour workshop. Okay, so now the money is very clear that we need, like 5 hours to a pay to every learner. And cha-ching, we can figure out how much this is going to cost. Now, how many staff members do you propose completing this education? That's another thing that happens in most of our hospitals is something happens bad and they say, teach everybody how to do that. And we look at them and say, why should we teach everybody when it's only the one unit that has these patients, or it's only the one role, the nurses or the unlicensed assistant personnel, or only the patients that have this. And so that makes it a much more manageable learner population, but this, blanketness. So make it very clear who needs it and get those numbers. When do you propose scheduling this? And anymore, this is really an important point. You get it all together and you say, okay, we're going to just roll it out as soon as I get it together. Oh no. Not only are there holidays, but there's all these other initiatives going on in your organization. Somebody's rolling out a new pump and somebody's doing, the new update of the documentation system. And, you have to have an awareness of all those initiatives and say, we want to wait till the documentation system is done. We're going to do it before the holidays begin. We think we can, get everybody through the module in about a 3-week time frame, so that they can see you're being realistic in your timeline. And have you discussed these ideas with key stakeholders and the challenges for that matter? And a lot of people think of stakeholders as only the people with money or the decision makers. There are so many people that are important in stakeholder groups for successful implementation of a change. And do not forget about people like your environmental services or housekeeping team. I remember a project where it was a turnover patient rooms. They were trying to reduce the amount of time that it took to get a patient up from the emergency room. And they put all these things in place. And absolutely nobody talked to housekeeping about how they were supposed to respond and, make these things happen. And they had to flip the room. And I'm like, that was a big gap in that implementation plan. So be sure that, you really consider all the players that might be involved. Gathering the development time, the time it will take to complete the learning, the number of learners. We'll need all of this later on when we're going to do calculations, because those are some of our numbers. Okay, so we talked about the evaluation plan. We should also, do a little more on that. And as you said earlier, this is such an important time, an important portion. What outcomes will be measured to indicate if the situation is improving, remains unchanged, or is actually getting worse? Patient outcomes or pressure injuries, med errors, readmission rates. There's so many patient outcomes. A lot of these are metrics that all of our organizations are constantly counting and following. So we have those numbers available to look at. There's a lot of employee outcomes. I mentioned preceptor satisfaction and retention. There's turnover. There's perceptions of incivility. There's comfort in talking to patients. I'm working on one now on gun safety education. And, our providers are telling us, I'm not really comfortable talking about gun safety. And the fact is that it's a major health issue for our pediatric population, and guns in the homes. And it's not that you can't have guns in the home, it's that they need to be safely stored. And kids need to understand when they go into somebody else's house, even if you don't have guns at your house, that you should, be sure that your child is protected in those other environments. And so we look at things like that become this even bigger outcome, organizational outcomes, patient volumes, number of publications. I love that one because a lot of organizations, that's part of their rankings to say we published this much and we've had people present at national and international conferences. And so those are things we're counting. The cost of agency personnel, that's a great one. And orientation time. What is this unit's typical or average orientation time? And if you do something better with helping your new nurses transition, are you reducing their orientation time? Finally, let's say a little bit more about that last component, and that's the economic impact. This is where you calculate the costs of developing the learning experience and providing it to the learners. The total expenses are then counterbalanced with the total benefit in all of the formulas. So what is the total benefit? If you are charging money for a program, the tuition and the registration fees will be part of that benefit. But most of us in professional development do not have an income. Instead, the total benefit is the cost avoided by fixing whatever your problem is. If the problem is catheter-associated bloodstream infections, the average cost of a CLAPSI is $46,000. If your education avoids one CLAPSI, you avoid spending $46,000. If your proposed education costs $7,500, you're way ahead.
Mm-hmm. Well, I think that's an important thing, I mean, especially in our world where we're talking about nurse residency programs, and they can be fairly expensive to get implemented. But when we start talking about, even if we save one nurse from quitting, there you go, right? So I think knowing what those numbers are and using those to your advantage here when you're making your case is so important. And I find that a lot of people that I talk to don't know what it actually costs to implement something like this.
When I think of nurse residency program revisions or changes, and let's say you were overhauling it and you spent $20,000, to revise it, and you had 45 participants in this cohort. Since the average cost of a nurse turnover is $52,350, your expenses, even though it's $20,000, is still very reasonable because, as you just said, if we save one person from turning over because we really improved our programming, then it's all worth it. And the beauty of that, I don't think a lot of people understand, if we spend that $20,000 to do that revision, remember, we're going to benefit from the next cohort and the cohort after that. So, you're really only measuring it for the first cohort, but the reality is you're going to continue to reap the benefit for cohorts after that. So as much as that sounds frightening to really invest in revision, it's going to play out as a very big benefit when it comes to measuring that turnover. Teaching you how to calculate the cost per participant, the benefit cost ratio, the return on investment. Honestly, it would be very difficult in a podcast because I would need a board to chalk on or something. Instead, I would refer you to the series of articles entitled Measuring the Value of Professional Development Activities, which started in 2016. We published them in the Journal of Nursing Professional Development. And our co-author work group actually expects to publish a 6th article in that series, hopefully in early 2025.
We will be sure to link those in the show notes, and so people can have the link directly to find those.
Perfect. That's excellent, because those first two and the 2016 one, they were how-to. We gave examples and then we did calculations, and people just loved that very concrete. And you can go back to that even though they're 5-8 years old. The other thing is that we introduced the first of what we've called the known cost table. And what we did was we searched all the literature that was out at the time, and anybody who published the average cost of something, the average cost of a bloodstream infection, the average cost of a urinary tract infection, average cost of turnover, average cost. We put them in a table and gave you the reference for it, so that in one table you can quickly look and find sources for these average costs. So it has now been called the known cost table. We updated that in 2018 and again in 22, and we will again do that in 25. It doesn't necessarily include every cost that's out there, but you have to keep in mind that this isn't something that people run around calculating all the time. It takes a lot of resources to find the average cost of one of these things. And so if somebody did it every 6, 8, 10 years, that would be fabulous. And then what we need to do is look at, let's say, $2018 compared to $2024. This would make this thing, all the higher. So those known cost tables are very useful. Another source, and you actually mentioned this in the beginning, was the NPD core curriculum. In the newest core curriculum, it's chapter 26, where I describe how to do all these calculations. Now, sorry, Nicole, once I get started with explanations, I hardly come up for air. What else should we be talking about?
No, this is all good. And that is, I think that's great information. And I think it really does give us some of the good definitions and things to sort of think about. And we will link all of those things that you mentioned as far as the articles, the known cost table, because that's on the AMPD website. And we can even link the core curriculum for anybody who's maybe interested in that. So, I think...
Oh, wait a minute. I do have one more thing. When you said linking it to the ANPD known cost table, I do need to explain something. Every one of these are different. So the 2016 known cost table that was published, the 2018 that was published, the 2020, which is on the NPD site, the 22, which is published, and now soon to have the 25. The reason why I say they're different is each time we go to publication, we always have word limits. And so the publishers look at us and say, you know what, you don't have enough space. Why don't you get rid of all of these known costs that are, more than 5 years old? Well, I just told you a few minutes ago, sometimes nobody's published on anything with it. So that, 2018 number was the best we got. Well, if you look at the current 22 and they don't have the number in there that you want, well, then look back at the website, ANPD's website, which, by the way, we could put a lot more on that one. And then if that doesn't have it, go back and look at the 18 or the 16, because you may find that there is a reference to the thing you're looking for. The problem is there's just not a way to put all of it in one place. So I always want to tell people that, because they print off one of them and it's like the thing they hold on to. And I'm like, well, wait a minute, because one of the other ones might actually have the thing you're looking for,
Sure. Good to know. Well, I think, first making the case, that's obviously the first hurdle, and getting that approval to implement a program. But then what we run into, or a challenge that I see a lot of our partners have, is that they need to continue to garner this support, right? And this buy-in. And so I think a key piece of this comes down to our communication, right? How do we communicate the value to all levels of leadership once we've got that financial approval? So maybe you could talk a little bit now about any strategies that you maybe use to effectively communicate the value of, let's say, a nurse residency program or any other NPD activity to stakeholders and decision makers. What can or maybe should that look like?
Well, first, who are your stakeholders? And, that always depends on what your project is. The obvious ones to me are unit managers who hire your residents, the NPD practitioners who are the extension of the central or the system educators who run the residency. You have to talk with both regarding their expectations of the program and of their residents. Do you touch base with both groups as the program evolves? Do they feel that they can contact you when they have challenges? Do you formally evaluate the program and give them the opportunity at the end to give feedback? You want informed stakeholders who will not be surprised by the occasional unexpected problem. Another stakeholder group would be the nurse residents. How are you getting feedback and responding to their input? Senior leadership, that would be another group. They probably provided the funding. So are you giving them, closing the loop and giving them feedback? The presenters, that's another group. The people who come into your program and present, who, you have to work around their schedules and they have things that change. And then you tell them, no, you got to do this. And they feel pressured. And sometimes they say, you know what, I just can't deal with this anymore. And you're like, oh man, when you lose a good presenter. So you got to know what their needs are and work and be flexible. And even the patients who fundamentally receive the quality of care. Do you have, there's all kinds of ways that we incorporate. Let's consider each one. Senior leadership, keep them abreast of the successes and the struggles of your program through quick email or one-page things. The presenters, are you juggling, because you don't want them feeling frustrated and you don't want them to give up on presenting. And as far as the patients, they are stakeholders of your care. Do you incorporate maybe a panel of patients for the residents to hear from those experiencing the care? The insights gained by the residents are invaluable, and increasing patient satisfaction affects the organization's reputation and utilization of services. The key message here is ongoing communication with all the stakeholders, and that it's two-way.
And I think that is great, because I think that sometimes people are great about maybe asking for feedback. Maybe they, ask the nurse residents or the preceptors or the unit leaders, how are things going? But then they fail to kind of close the loop, right? And give their perspective of it, or the outcomes that they are seeing and measuring. So once that initial sort of implementation is approved, it's like people kind of if you're not constantly communicating back to them, they kind of forget about it, right? And so I like that idea of continuous, and I like that you point out the fact that are they comfortable with really sharing their honest feedback? And so having those really solid relationships with these individuals, I think is so valuable as well, because not that everybody's feedback doesn't count, but like the engaged participants, the engaged stakeholders who are really on the pulse of what's going on. I don't know how to put that nicely, but like their feedback is that much more valuable to you.
They're informed. You need informed stakeholders, which the beauty of keeping your stakeholders informed is that every once in a while things happen. Bad things you didn't want to happen. And you have to go with your tail between your legs and say, uh-oh, this happened. The informed stakeholders will say, wow, that was, unplanned, or I guess we have to deal with it, because they've been right on it with you. If you just show up and you haven't talked to them for a while, they're going to say, what kind of program are you doing down there? I think maybe we should just wipe this thing out because, it looks terrible. And you're like, wait. And so, yes, keep your stakeholders informed.
Yes. Okay, so we've made the case to implement. We're continually communicating, as you said, its value as we operationalize the program. Now budget time comes, of course, and why is education always the first place to cut, right? It seems like it's so easy to say, well, we just don't need that thing anymore because that's eating up part of the budget. So I think now what, right? What are some of the metrics, some of the data that we could really focus on measuring kind of the organizational impact to sort of prove to the financial leaders that this continued investment, even though the budget is tight, is so key?
Well, there are a slate of outcomes that the nurse residency program contributes to. We already mentioned the retention and the turnover, and demonstrating the cost to your organization. Current turnover rate is really important. If you look at your turnover from last year and it was whatever number it was, 20, and your program will reduce that number, then that's a huge 52,000 a nurse. Show the organizational numbers of how the new grad compared to the experienced turnover. This is another thing, because you want to show that you're retaining these new grads, and it is a different group who is turning over in your population. So that's another angle with turnover. Show the evidence from the literature of the effects of standardized accredited residency programs. I think some programs get into the situation where you've had it going on for 8 years and nobody remembers what it was like before we had the residency. And so they say, you know what, I don't know if this make any difference because, we've had the same retention, 2-3 years in a row. So what do we need it for? And you're like, oh no, if we get rid of it, we're going to spike. And so sometimes that demonstration from the literature that shows places that don't have programs versus places that do will impress that stakeholder. Propose your improvements, because you really should at least every couple of years be taking a very heavy look at your program and say, what is it that we should be revising, bringing up to date, changing with the times kind of things. And, don't be modest with your numbers, and then compare that to 1 or 2 people, further people being retained. Now, there are plenty of other outcomes that you could be tracking for your argument. Intent to stay. I love that one. Before somebody leaves, they always grapple with the loss of what they thought was going to be this fabulous job. The honeymoon is over. If asked, they will report that they would consider leaving. Absenteeism. Less engaged and satisfied workers take days as they earn them, and they have no problem calling off. I couldn't get this day off, but I'm taking it off anyways. Oh, I'm sick. I have a cough. And you're like, don't you feel bad that you left your team members high and dry? And they've already disengaged. So a person who's taking a lot of abrupt days off tells you that, that person's probably on their way out. You hope that your programming keeps people very engaged. Staff engagement in general. Are your past cohorts involved? So if you look back at the people who were in your cohort last year or the year before, are they on the clinical ladder? Are they in committees? Are they seeking certification, returning to school? I mean, do you see them engaged compared to, whether you compare them or not, to staff that weren't in the program? The fact is showing that engagement. Extended orientations. Are residents supported with both their preceptor relationships and the residency? And challenges would be recognized and responded to sooner because of this kind of double support. So, you usually avoid those extensions. Extensions of orientation are expensive. When you think that, your average orientation on your unit is 8 weeks or 12 weeks or 15 or some ICUs 6 months. And now you have this person add 3-5 more weeks. That's a lot more time that they are not taking a full patient assignment, and that's expensive. So if your program can help with that, that makes a difference. Reported events or incidents, depending on your organization, what you call them, that involve residents. A lot of you have ability to track, and you can see if your residents, current residents or past one-year cohort residents are involved in events. Staff satisfaction, patient satisfaction, employee grievances, especially ones involving residents. You probably do the Casey Fink surveys or some other survey that's a serial surveying, and you can see them move or progress in various areas. The cost of agency personnel. Because we're trying to get these new people up to snuff, we've got all these agency personnel that we are paying until our residents become competent and confident and then stay. So, we can save that cost. And of course, job stress. Some organizations do a really good job at measuring that. Keep in mind something I mentioned earlier, that risk of ignoring this problem can also be kind of an approach in your outcomes. With unrequited turnover, the increased cost of agency personnel, likely absenteeism, staff satisfaction, job stress, they all snowball into each other. All those metrics will suffer.
Yes. And I think that is always a great sort of approach to take if you're not getting where you need to go with the information that you do have. That is all great food for thought when it comes to, and I love that you gave so many different examples of outcomes, because again, we can get so pigeonholed into like, we're only looking at this, and if this doesn't do what we think it's going to do, then this must not be working. And that's just not the case, right? Like you said, there are so many different avenues you can look at.
Mm-hmm.
All right. So just like all things, how we support nurses will continue to evolve over time. As you look at current and future trends, what new things do you encourage NPDs to consider? Do you see different ideas regarding future workforce development needs, the role of demonstrating value for professional development activities? I guess just when you kind of look out there, what are some things that come to mind?
Future workforce development needs. That's a great question. I think how I'll respond is, I have called this the last frontier of healthcare. And you said, what do you mean? Over the past 15 years or so, we have had an in-depth approach to quality improvement in healthcare. We grabbed all that low-hanging fruit by standardizing all the checklists and the bundles, and for so many things, resulting in massive reduction of preventable errors. We now have plateaued with very little improvement, or if anything, you see kind of a seesaw result on these charts. But we haven't gotten to the zero, not consistently. I believe this last progress will only happen if we invest in relationship building and communication between our team members. We have generations now who have been raised in small family setting. Maybe they have no siblings, so they've never had to learn to do the negotiation for something in your room.
They're not all a middle child like me, right? Where you got the negotiation thing down pat.
Yeah, it's true. Middle child. I'm a middle too. I'm a middle of 7. I negotiate up and negotiate down. Dependency on technology. I don't have to talk to you because I'm clicking and popping on my phone. Social media influence. That we actually have the concept of friending. That somebody on social media is my friend because I clicked a button is weird. And so if that's what you think a friend is, and 24/7 news cycles. The fact is that when things keep flashing in your face, oh, how horrible, or oh, how terrible, wonderful, it really influences your thinking. This has contributed to nurses, doctors, the entire team feeling uncomfortable communicating with patients and honestly with fellow team members, especially when something is not going well. We need to invest in relationship building and communication skill building. Unfortunately, you can't just throw a knowledge-filled module at them and say, hey, read this and you too will be a good communicator. This involves teaching strategies to help them listen and respond, role-playing with scenarios, cognitive rehearsal, role modeling, simulating communications, de-escalation techniques, And these skills take time and practice with a lot of reinforcement on the job and with continuing development opportunities. These used to be called the soft skills, as if they were not quite as important as the hard skills, like starting that IV. They receive lower priority and therefore fewer resources. I truly believe we must embrace the ways to build relationships between our teams and our members of the teams as expected and routine, that this is just a routine thing. I also think NPDs are capable of creative and effective ways of facilitating better communication. For example, practice feedback between preceptor and orientee. Simulate calling the provider at 2 a.m. for a deteriorating patient. Practice scripts and structuring difficult conversations for win-win for all parties. And delegation exercises. That's another place that people struggle. So when I say last frontier, I feel like if we have to face this, and it's only with that will we nudge ourselves to that 100%, or in the case of errors, 0 errors.
It's so interesting that you say this, because you're not our first guest on the podcast to kind of call out this communication gap that we have, and how it's just with technology and with the way, we're raising our kids these days, it's just going to continue to progressively get worse. And so we need to have some attention on that now. So Kathleen, you have shared so much great information with us today. I feel like we could talk and talk and talk, but all this information that you've shared about making the business case, walking us through, the idea of the economic impact of this initiative that they're going to be proposing, talking about sort of that continued communication regarding value and where you kind of see us going into the future. I really think that this episode is going to be of tremendous value to our listeners. So thank you so much for sharing all of that. But before we go, I always have one last question that I like to ask our guests when they come on the podcast. And that is, when it comes to transition to practice today and this sort of topic of sort of making the business case, what's one thing you either see organizations maybe doing wrong or wasting resources on that really isn't making a difference? Or if you want to take more of a positive approach, what's one thing that you see that really makes a significant difference that you wish more people were doing?
I think I'm going with a positive approach, because I really see it makes a significant difference, and I wish more organizations were doing it. And simply put, it's investing in developing communication skills and relationships. And I keep saying those two things separately. One is communication skills. There's a lot of things we can do around that, scripting and practice difficult scenarios, et cetera. But the other is that relationship building. It is important that we do the potlucks, that we welcome the new members, that we celebrate the anniversary of this and that we have our parties, because those are the things that become the glue and the memories and the things that pull us together in our relationships. And when there are relationships, someone picks up the phone and they call the person and get to the bottom of the situation. That's very different from, well, I wrote an order, hope they interpreted it right. On the other hand, when the expressions are used kind of anonymous, like they didn't do it, or what were they thinking? Do people, when they don't assign a person that anonymity, that's not my problem. That's when scary things happen. Relationships are essential for catching those near misses. And when somebody's having my back, there are too many things changing and moving in our environments. Healthcare is so dynamic, and so the knowledge and the new things ever changing. Nobody can keep up with it. That's why we need to have each other's back. Nobody can capture all those details. We need teamwork and effective communication to keep our patients and ourselves safe.
Awesome. Well, I think that is a great note to sort of end on, and I totally 100% agree with what you are saying there as far as relationships and communication. And I loved actually the example there of like, still do the potlucks. That's the glue that keeps us kind of together, right? So thank you, Kathleen, so much for joining us today and sharing your wealth of expertise.
Well, thank you for having me. I had fun.
Wait, before you go, I want to make sure you know all about our suite of resources you can use to support your new graduate nurses. This includes our Academy, a coaching program designed for organizations as they prepare for the implementation and ongoing sustainability of a nurse residency program. Work one-on-one with residency program experts to make sure your organization is residency ready. Our Clinician Wellbeing course is an asynchronous online course that aims to enhance the well-being and resiliency of healthcare professionals, equipping them with the necessary psychological capital to navigate challenges inside and outside of work. Supporting Nurses is another asynchronous online course for preceptors, mentors, and coaches to learn the skills they need to support any new hire. Both of these offerings can be used as a standalone professional development opportunity or to augment any nurse residency program. And we can't forget about the program that started it all, the online nurse residency program. This includes a comprehensive curriculum designed to support new graduate nurses applying all the knowledge they learned in school to their practice. We focus on professional skills, personal well-being competencies, and new graduate nurses even get the opportunity to create real change in their own organization. Offered completely online and in a blended format, this program is highly adaptable to all clinical practice settings. You can learn more about all of these programs and more of what we offer using the links in the show notes below.